Thanks, Jim. Well, John Clifton, is it? The last man that joined us.
Yes, it is. That's right.
Yeah. Yes, John. We don't give any medical advice, but we're happy to share ideas. No. It would have been good if you could have got onto the actual Zoom, but anyway, telephone's okay.
Yeah.
We can live with that.
Yep.
Would you like to, seeing you're the first time you've been on, and Alan, one of our members, has got to go early, would you like to give us an update of where you are? Then we can have a talk about your situation.
Okay, can you hear me?
Yeah.
Can you hear me now? Yeah, okay.
Yes.
Well, my name's John, and I'm 72. I was diagnosed with prostate cancer in about 2019. I had a prostatectomy sort of fairly soon after that. The levels have been, they were steady for a while, but recently they've been going up a little bit sort of faster. I'm now at 0.21. Can you still hear me?
Yes.
Yeah. I'm now at 0.21. I haven't had any further treatment yet, but I'm going into the hospital and in the place where I live, which is Ipswich. And I'm going to see what they've got to say. So if anyone's got any light to shed on that sort of scenario, I'd be happy to hear it.
What do you expect that they might say to you?
Well, I'm thinking from my reading, it's either some sort of radiation therapy, or combined with some sort of hormone therapy.
Have you had any scans? Have you had any scans to indicate where you might have an issue or anything like that at this stage? Or
I've had sorry about that. I had a PET scan probably a month ago, and the hospital called me back and wants to see me again. And the PET scan showed up something, but I'm actually not 100% sure. I think the GP indicated that it might have been in some of the pelvic lymph nodes, and but that's about as far as I know at this stage.
Right. So do you know how many spots there were?
No, they haven't said that yet, no.
Right. Thank you.
I think it's a small number.
Has anyone got a comment to make on John's situation where they think he might be headed in the next line of treatment?
I can if I will.
Yes, Kingsley.
Mine was probably a bit similar. I had, the prostate removed just over 2.5 years ago, and they found that it had spread on a PET scan after and that, I ended up going through 7 weeks of radiation as well as I went on hormone treatment as well. So chances are that may be what they will do.
Alan? Thanks, Kingsley.
Yep, sure. John, a couple of things. One is you've had the PSMA PET scan at a pretty low PSA. So by the sound of it, they've found pelvic lymph nodes which are responding to the scan. You definitely have had a recurrence of PSA. It tends to point in the direction of the treatment options which you have. One thought you might want to consider at this point, given that you've got recurrent PSA after an RP, is that you may want to consider seeking the services of a medical oncologist as distinct from a urologist. Urologists can prescribe treatments, but it's not their specialty as it is with a medical oncologist, particularly those that specialise a bit in prostate cancer. That's just something for you to consider. You can either ask your oncologist for a second opinion, or you can ask your GP to do it. But it's definitely a timely, I would suggest. The second point might be that a medical oncologist may prescribe a combination of hormone treatment and chemotherapy. And if he or she does, don't be scared by either of them, particularly the chemotherapy. A lot of people a bit suspicious of that because of the reported side effects, but it is a well-validated option for a treatment at this stage that you have, and it definitely, from the trials that have been done, is pretty helpful. You'd only have 6 rounds of it, so if you're youngish and fit like you sound to be, don't be too dismissive of it. Another possible option would be, as well as ADT or hormone treatment, would be possibly a second generation hormone treatment. A few of those, but they're probably best left to discuss with the oncologist. It's all about side effects. They both work. Both options work pretty well similarly, but in terms of which way an oncologist would prefer to go and what side effects you and he might discuss. They're not severe, not likely to be severe, but that's something for discussion. So that's it from me.
Thanks very much for that, Alan. Yes, Yanni.
I'd like to go in a slightly different direction, John. If you've you said you had you think you've got a small number of metastases in the lymph nodes. If it is indeed a small number, 2, 3, 4, before embarking on anything more systemic, you might want to consider getting stereotactic radiation to target those individual sites, because the stereotactic radiation can focus in very specifically on locations, and they could perhaps get knocked out for 6 months, a year or something before you have to embark on something else more systemic if the cancer does come back. I also would suggest that you start keeping records of all of your scans, start keeping details of all of the information that's provided to build up a personal record that you've got your hands on, that the doctors don't necessarily keep, because as Alan suggested, going from urologists to oncologists to radiologists to whoever else, it's always very useful to be able to just take your own stuff with you. And also, if you do choose to embark on some sort of hormone treatment at this stage, which I personally don't think is necessarily a great idea, because the sooner you embark on hormone treatment, the sooner it, in a matter of years, will become hormone resistant, castrate resistant, but that you I forget what I was going to say now. That's one of the side effects of hormone treatment.
Thanks, Yanni. Too many holidays. Yes, Charles.
Just a quick, Alan, again, I totally agree with everything Yanni said. The possibility of radiation treatment, and there are more than one version of it, depending on where the lymph nodes are. But stereotactic treatment can be quite effective and can even be curative in some situations. So it's certainly a good one to pursue with a radio-oncologist, as distinct from a medical oncologist. So it's definitely worth having a conversation with both. And with regard to one other thing, if or when you do start on systemic treatment involving hormone suppression, it wouldn't be too unusual, if you've got good response, to actually have periodic holidays from it. It's called intermittent hormone therapy, and I certainly had that experience for quite a few years before going on to a permanent, regular 3-monthly dose. So that's just another aspect to consider as well.
I'll just give Charles a go, Yanni. Charles wanted to say something earlier.
Yeah, I agree with Yanis about trying to find out exactly why it's increasing. If you can find out which lymph node it's in, from a PSMA PET scan, is it? I forget what it's called. I had I've had a couple of episodes. I've been treating for more than 20 years. I had a couple of episodes of it going to the lymph nodes. At each time was just one lymph node, and the radiologist targeted that lymph node. The first one, I got 2 years disease-free out of a quickly growing PSA, and I thought it actually cured it, but it hadn't. But I got 2 years out of it, and so to find out where it is, it's probably better than doing a blanket hormone therapy or a blanket, the whole body. But if you can find out if it's in one particular, or two particular, or even more particular lymph nodes, you can target that. That's it.
Thanks, Charles. Yanni?
I just remembered what I was going to say. If you do choose to embark on hormone treatment, then make sure you go and get a bone scan at the very beginning, because one of the consequences of hormone treatment is a loss of bone density, and it's really, really useful if you've got a benchmark reading to measure against as you progress down that track.
Well, the bone density may not progress. I mean, you can have medication that prevent progression. So I totally agree again with Yanni. An early bone density test if and when you start hormone treatment's an excellent idea. And sometimes the docs forget to mention it.
Tony Maxwell?
I've been on first and second generation hormone treatment now for 21 years after a failed radical. And back in 2022, my PSA was rumping up again. It got up to about 15. And I had a PSMA PET scan, not just a PET scan, a PSMA PET scan. And it identified that there was just one major lesion in the pelvic lymph node. So I ended up having stereotactic radiation for that. And my PSA immediately started going down again. For the last year, it's been virtually zero. And I have had no bad side effects from the treatment. And it was only 5 or 6 treatments. So I fully recommend that you need to think about a PSMA PET scan, and you need to talk to a radiation oncologist who has the capacity to do stereotactic radiation. That's my thoughts.
Thanks, Tony. John, stereotactic is just for 5 spots or less. So hopefully you've got less than 5 spots or 5 spots or less, and that'll give you, they can do high radiation to that area, which will help your cause. On hormone therapy, I've been on continuous hormone therapy since April 2011 on Eligard, and I tolerate it fairly well, but not everyone tolerates it as well as what I do. And so no one can tell you how you're going to tolerate hormone therapy until you actually try. But the likes of Yanni and Jim would suggest a different type of hormone therapy these days than Eligard. So they would, because since I started in 2011, there is another hormone therapy out there that people, I think, tolerate better than Eligard. So they do, like Triptorelin or whatever I think is its name. But Yanni or Jim will know about that. Jim?
Yeah, Triptorelin. The choice of hormone therapy is complicated by where you are and how sophisticated you are and so on. The safest one to give you is an injection called Zoladex. The reason it's safe is that there is no mixing of the dose required. All of the other treatments, including triptorelin, have to be mixed very, very carefully before they're injected. So depending on where you are, your doctors may recommend Zoladex. The other ones are better at keeping it. But sorry, I'll start with triptorelin, particularly, is much better at keeping your PSA low and avoiding it even getting temporarily high, whereas Zoladex does have some temporary highs. Have we heard? Are you hearing us, John?
Yes, I'm listening. I've just got the phone on mute as suggested. Yeah.
Okay.
Yeah, that's all very helpful. Mm. All those fellows have been helpful so far. It's interesting to hear that. I hadn't heard the terms stereotactic radiotherapy. And it's interesting to hear what you're saying about the hormone therapy too.
Okay.
I'll just go over mute now.
I'll come back on that as well. What you need is a very high dose to the spots. Although people are calling that stereotactic radiation has a much wider definition, and the radiation that you receive may not be stereotactic radiation, just so long as it's high radiation to that spot. Stereotactic radiation has a number of different definitions, which complicates things, but you're after a high amount of radiation to that particular spot. Thanks, Nev.
Thanks, Jim. Have you got any questions, John, at all?
Yes, I'm a little bit concerned about the radiation idea. I appreciate it can be focused onto particular points, but in doing that, it's also got to pass through other organs, valves and bladders and goodness knows what. So I'm just wondering if anyone's had any experience with sort of associated damage during that type of process. Over to you guys.
Peter? Did you want to say something, Peter? You're on mute.
Got it. You mean Charles? Oh, no,
No,
Peter.
no, Peter. I thought Peter had his hand up.
No, I did. About 12 months after I finished the 39 sessions of radiotherapy, and that was external beam, I developed radiation proctitis, bleeding from the bowel. So they had to go in and do argon ablation therapy to seal off those tissues that were still bleeding. And a year later, I developed urinary incontinence because the bladder wall had been hardened via the radiotherapy. And it got to the stage where they had to insert an artificial urinary sphincter about 12 months ago, just so that I could have some sort of quality of life. So there are issues, but it was just that I was probably one of the unfortunate ones that it happened to, because I've heard a lot of people have no issues whatsoever.
Can I say I just had, I was diagnosed a little while ago with radiation cystitis. I had about 3 months of constant bleeding, and they referred me back to urology and that, and had scans and all that stuff. And last Friday, I had another rigid cystoscopy to go through and do the lining of the bladder and that. The other thing they found when I had the cystoscopy to check and see beforehand, a surgical staple had been left in there. So that they managed to remove that last week as well. But with regard to incontinence, I know that. Yeah, it's 2.5 years for me, and I'm still experiencing incontinence with it. So,
Yes.
Jim here.
Yes, Charles.
All right.
Yeah, I agree. You know, you really need a PSMA PET scan to find out where the problem is. You know, if it's and how widespread it is. It's only a low PSA, so it's not likely to be. You know, I wouldn't think it'd be likely to be. More than just a few lymph nodes. And as far as damage from radiation, it probably depends where the lymph node is. It could be quite away from all the organs. It could be up high near the, or it could be anywhere. You just and treating it. As I said, I've had this done twice. But I did get bladder cancer, but it wasn't from those ones. It was from the earlier treatment, I think, because that's where my initial treatment was for external beam radiation and also high dose rate brachytherapy. And in the end, last year, I had my bladder removed. The other thing is I was on Zoladex for more than 20 years. And after initial some side effects, it dissipated, and I didn't have any problems. But just after 20 odd years, it stopped working, and I had to get on to something else. Anyway, that was my 2 cents worth.
Let's start.
Jim here. Can you hear me, John?
Yes, I can.
Okay.
Not sure what's happening.
I'll now give you the bad news. All of the treatments available to you from now on have some side effects. As Alan said, it'll be partly looking at your body and the side effects that might affect you, but there will be a risk with all of the treatments that are available. As Peter said, most people who have radiation don't get incontinence issues, but some people do. Peter's been one of those who do. You pays your money and it takes your chances.
Sure. What are the chances, though, Jim, of
well, the chances
the
chances of incontinence after radiation are very low, but it can be quite miserable if you're the one who misses out.
We'll go to Yanni and then Alan. Yanni?
And that's one of the reasons why I suggested stereotactic radiation, which is far less likely to damage adjacent organs, because how that works is there are multiple radiation beams that are weak in themselves, but they come together at a focal point, which is where the lymph gland cancer is, or the bone cancer, or whatever it is, and they then magnify into a much more higher volume radiation. So they then zap just that point, and the organs that the individual beams go through don't get damaged, because the strength of each individual beam is relatively negligible. Regarding issues like bleeding from your bladder or urinary tract or whatever, been there, done that, and it wasn't pleasant. But I've embarked on hyperbaric treatment, which is the chambers that divers go into if they've got the bends, which are such that you breathe pretty much full oxygen whilst you're in the chamber. And the hyperbaric treatment encourages new blood vessels to grow around the bladder, on the inside of the bladder, to compensate for the ones that get made brittle by the radiation treatment if you have a more holistic radiation treatment, generally called image modulated radiation treatment, or IMRT.
Yeah, Alan. Thanks, Yanni. Alan?
Just quickly, Yanni's got most of what I was going to say, but just so you're aware of the jargon on radiation therapy, it was Charles who mentioned external beam radiation therapy. That's the longest established traditional form. It's not quite as precise in terms of collateral damage as other alternatives. There's an intermediate precision version called IMRT, which means intensity modulated radiation therapy. That's considerably better in the way they can map the radiation intensity around the target, so you don't get as much collateral damage. And as Yanni said, the ultimate in terms of high precision, which is certainly relevant for lymph nodes and it's becoming relevant for slightly more extensive tumours. Intensity modulation, so-called stereotactic has a couple of pseudonyms. One's called SBRT. It's another version of it is called SABR, but it basically means the same thing. It's stereotactic whole body radiation. That's like spot welding, I suppose the best description. Very precise. I've had quite a number of those personally, both for recurrent prostate cancer, lymph nodes, and more recently for thyroid, metastatic thyroid lymph nodes. So I've had a fair bit of experience, and as Tony said, as Yanni said as well, not a bad start, but that's really between you and your doctors.
Thanks very much, Alan. I hope we haven't overwhelmed you with comments, John. Is there anything you'd like to ask, or John?
Not really at this stage. At this stage, I don't know what the PET scan result was. As I said, I have had one, but I'm finding out on Monday, this coming Monday, and what they actually found, whether it was one or two lymph nodes, I'm not sure, or more. So I'm just where they are. What the medical, I don't know any of that yet. But there was something that they found, hence the rising PSA.
Well,
so yeah, it's sort of been very helpful listening to the fellows talk, that's for sure.
With a rising PSA, there's going to be something somewhere. You can be certain of that, unfortunately. You've got my phone number if you need to talk to someone, and I can organise that. So, but you're more than welcome to join next month. Again, so you are. There's no worries there. So, and on the third Wednesday at CSI in Ipswich, the Ipswich support group have a coffee get together there, and if you want to come to that and have a chat there on the third Wednesday morning of June, you're more than welcome. So that's at CSI.
Okay, I'll do that.
Yeah.
Third Wednesday at CSI. Okay. What time is it?
10 o'clock. It opens at 10 o'clock. Yeah.
Okay, no worries. Okay.
Good, John.
Right.
All the best. Roy.
Okay, well, thank you.
No, you're welcome. Roy, can we get an update, or? You're on mute. You're on mute, Roy. Roy, you're on mute. Unfortunately, we can't hear Roy. He hasn't turned it off mute.
Let's all show him some ears. Roy, we can't hear you. Roy, we can't hear you.
The bummer. So it is. Righto. If Roy can't get it off mute, we might have to move on to. Does someone else want to give us an update or have a? Yes, Mark. Sorry. Thanks,
yeah, I
Mark.
think that you can hear me.
Yes, yes.
Yeah, I think before the last meeting, I can't remember if I'd got the results for the scans but it was a PET scan, a CT scan, and a bone scan. They all turned up negative. So I started on darolutamide. The PSA was 4.5 when I started on those 2 months ago. A month after I started, it went down to 0.49. And then I just saw the oncologist again yesterday, and it was 0.17. So seems to be doing something. Yeah, still have no idea where it is because none of the scans showed anything. So I'm taking that as good news, that it just means it's not big enough to show up. But yeah, I don't know. So like I said, it was 0.04 at the end of radiation last year, and then the second one in December had gone up to the 1.26. So it was increasing at about doubling every month. So at least we seem to have stopped that and got it going in the right direction again. So yeah, that's where I am at the moment.
Thanks, Mark. We hope that continues for you. Any questions or comments to Mark?
I might do
Yes, Alan.
back off shortly. I think I remember your conversation last time, Mark. It's a bit unusual, but not unheard of, to have a significant PSA, which would, I think, anything other than above 1 or 1.5 would be significant in terms of sensitivity to a PSMA PET scan. But not all prostate cancer expresses PSMA, which it needs to for that scan to be effective. There's a percentage, could be 20-25% of people that don't express PSMA, and in that case, there is an alternative, just so that you're aware, an alternative kind of PET scan called an FDG PET scan, which is likely to pick up what PSMA doesn't. It's actually used in conjunction with the PSMA PET for certain forms of systemic radio treatment, but it's just something that you may want to just raise with your radiation oncologist if you're concerned about it, particularly if the PSA starts to take off and the doubling time or the doubling rate starts to get down to a level of less than several months, which means it's accelerating away a little bit. And if in that case, you may just want to have another look at the different PET scan option.
Yeah, well, I had a PET scan just before I had the biopsy originally as well, and the PSA was 17 then, and that didn't show anything. So that's why they recommended me for surgery.
Well, that's quite
during the surgery, they found it in the lymph nodes.
Yeah, it's relatively unusual for a PSA that high not show with a PSMA PET scan, but it's certainly far from unlikely. If it hasn't at that sort of PSA level, I think I'd be asking about an FDG PET scan. Quite sensitive. It's a different sort of technology. It's looking for metabolic activity within the prostate cancer tumor, and whereas the other one's looking for the presence of a marker on the outside. So it's kind of attacking the discovery in a slightly different way. And it's if I were getting a recurrence, particularly if it was accelerating, I'd be wanting to pursue that line.
Thanks very much, Alan. Any other comments or questions to Mark? Yes, Gianni?
There is a derivative of prostate cancer called neuroendocrine cancer, and that is a bit more difficult to treat than PSMA avid cancer, prostate cancer. So if it is neuroendocrine, then it's a different regime of medication that you need to pursue than people with PSMA avid or cancers that give off PSMA.
The only comment I'd make there, Yanni, is that neuroendocrine version generally doesn't produce much PSA at all. It produces tiny bits. So if you've got a significant PSA reading, particularly one that's accelerating, it's less likely that that's the cause. It's not to say that it can't mutate in that direction, and long-term treatments sometimes do, but you're not in the long-term category, Mark, so I wouldn't be too anxious about that.
Thanks, Alan. Appreciate
Thanks,
your time
Alan.
today.
I'll have to disappear, mate. I'm sorry.
Yeah, no, really appreciate your input. It's all the best.
Thanks.
Roy, you can't get off mute. Do you want to just log out and log in again, and then you will won't be on mute when you log in, and we'll be able to hear from you then. If you go off the Zoom meeting and log in again and see if that works. Thanks for that. We'll see what happens with Roy. Anyone else in the meantime just want to have Damien, how are you going?
Yeah, good morning. Thank you very much. Interesting time since my my last visit. I did miss the last meeting, but I think the first time I had my first meeting, I haven't had anything done procedurally since then. My biopsy was triggered by a score, PSA reading of 5.7. And since then, I've had 2 other PSA tests. And I don't know if anyone would like to comment on this, but my first PSA since the 5.7 was 5. And then I had another one done about a week ago, and it's now 4.85, which is going down. But I have had the biopsy, which did prove that there was carcinoma in there. So has anyone experienced that before? I haven't had any treatment apart from the initial biopsy. Any feedback on that? Anyone had that happen to them?
Jim?
Jim here. There is considerable variation in PSA readings between readings themselves. If they do 2 readings, one after another on the same machine, they'll get different results because the stuff that they're using gradually dies, and they do calculations to try and adjust for that. But there are other things like PSA varies by season and so on. So it has to be a very big difference to be noteworthy.
Okay, so I mean, according to the doctor, the urologist who I saw only yesterday, he said that yes, your PSA might be going down, but it depends on the different labs for starters, because they were done by different labs.
Right.
And, yeah, and also the fact that I've had the biopsy and the biopsy came back positive, and he said no matter what, you still got the cancer.
Yeah. So that's the definitive thing. You've got the cancer.
Okay.
You can't compare different labs. You might as well put the time of day from your watch in, because they use entirely different processes.
Yeah. Well, anyway, look, it's all contained within the prostate, and he actually got me to talk to a guy who had only operated on in April. Young guy, just I don't know, 5 or 7 years older than me. I'm 62. This guy was there with his wife. He was 60, I think 69, something like that. And he gave me some pretty good feedback as to what I should possibly do, because of the fact, obviously, I'm concerned. I don't want the operation, but, you know, I also don't want it to spread. And at the moment, everything's contained. It's early stages. So I decided, you know, we've booked it in now for the 8th of July next month. Oh, sorry, in July, I should say, to actually have the prostatectomy.
Okay, so being the bad news fairy, if you know a ballpoint pen, like a Bic pen, the little tiny ball bearing in the end of that is actually 1 millimeter.
Right.
If you have a bunch of prostate cancer cells, 1 millimeter sphere, like that ball bearing, no scans can see it. So when doctors say it's confined, what they're doing is they're saying what we can see is confined.
Okay.
So don't ever panic if it comes back. If it comes back, it just means you need more treatment and different treatment.
Okay.
As far as your choices with the prostatectomy, your chances of urinary incontinence are fairly high. About half people after a couple of years have that solved. On the other hand, with the radiation, as you heard earlier today, it's mostly completely unaffected your urinary incontinence, but you can balance that out with other long-term effects. So no good news here, but the thing to mostly take away from this is don't panic if they tell you it comes back. It just needs you need more treatment. Thank you, Nev.
Thanks, Jim. Yanni?
Yeah, thank
I don't know how committed you are to the prostatectomy, but if you are, then start doing pelvic floor exercises now, because that's one way of really helping urinary incontinence down the track. Because blokes are born with 2 urinary sphincters and one of them gets turfed when the prostate comes out, and you need to understand how to control the other one.
okay. So they do actually take one out, do they? I didn't know that.
Yeah. So, yes, they do. And the pelvic floor exercises allow you to learn to control the muscles around the other one, so that you can effectively survive without that second one. And sorry, Jim.
Sorry. When you finished, Yanni, I'll come in.
So when I had my prostate out, I was pretty fortunate, I guess, because I'd done pelvic floor exercises well and truly beforehand. And when I was driving, every traffic light I stopped at, I did them and all that sort of stuff. I only had probably a couple of weeks of incontinence. But the other point I want to make regarding how wedded are you to having your prostate out, you could also explore brachytherapy, which is the insertion of radioactive beads into the prostate, which then have a zapping effect in a sort of limited radius area of each bead, and that has proven to be pretty successful.
Yeah, I did actually see a radio oncologist, and he said his advice to me was that he said, because I'm relatively slim and don't have much body fat, he said that the radiation wouldn't be very good for my bowels and possibly bladder, and he said there could be some scarring there. And I've also been told, and correct me if I'm wrong, is that if you have radiation therapy first and it's not successful, then it's a lot harder to have a prostatectomy afterwards because of the damage to the area. Is that something that you've heard of as well?
Jim, for that one.
Yes,
yeah,
Jim.
that's a furphy that's often raised. The reason it's a furphy is that no one who has radiation and it comes back and the prostate cancer recurs has a prostatectomy, because why would you want to? And you got an 85% chance of peeing yourself afterwards, because the major thing that happens after recurrence is always radiation. So if you've had radiation initially and it comes back, the next treatment is radiation. You can have radiation again. It works, right? So that's a bit of a furphy. Although that doesn't affect you, the advice you had from the radiation chappie that you're too fit, you don't have enough fat, sounds like very sensible advice to me. I'm not a doctor, but I have plenty of fat around there myself, and I've had the radiation and lots of radiation, and it's all going well.
Okay, yeah. I mean, he was referring to more the bowels than the bladder, and I mean, the last thing I want is damage to the bowel area.
Yes, because most of the rest of us have a good layer of fat around there, and it's useful in prostate cancer, not to you, but to inject things like Zoladex into. But there aren't many people as fit as you at your age.
Well, yeah, I try and maintain my health, but I suppose I was just more concerned, not concerned, but I thought, well, if my prostate or PSA is going down, I thought that would be good. But and I just thought that someone may have had the experience of had it go down and not had the operation because of that. So, I mean, I don't particularly want to have the operation, but I also don't want it to spread. And he told me of this guy's done a couple of thousand operations, he said, and he said he's treating some guys who left it in their early 60s, and now that in their late 60s that it's actually metastasized and spread out. And obviously that's the other thing I don't particularly want either.
I missed your Gleason score. What was your?
Oh yeah, my Gleason score was 7. It was 3 and 4, but it was only 10% 4.
Okay, so that makes a big difference. You're again, I'm not a doctor, but
Sure.
you'd be rated as not high risk at all.
True. For what with respect to it spreading?
Yes, indeed. Yep.
Okay.
Especially with that low percentage of 4.
Okay. Yeah.
With the three number coming first, that makes it low. With the small percentage of 4, that makes it not extra high at all.
But in that case, then wouldn't it? And this is where I'm kind of seeking advice from more experienced people like yourselves. Is it better to get it out early before anything else worsens, or just let it go and keep waiting and see?
Most usually, doctors would recommend withdraw that remark. A lot of people would be tempted to wait and see. But you have to make sure you are having regular PSA tests.
Okay.
At least every 3 months, and your GP can arrange those perhaps. But the other thing it depends upon is your psychology. So some people can't stand the thought of wait and see how it goes. Others, like me, are fairly comfortable with it. So,
yes, Shani. Thanks, Jim.
I'm a member of in Melbourne of another prostate group at Heidelberg, and there's a guy there who was diagnosed about 7 years ago with prostate cancer, and I think he was about a Gleason 6 or 7, and he was initially told to have an operation and have his prostate out. He went and got a second opinion, and that urologist said, "Nah, not yet." And he has since embarked on a regime of exercise, diet change, and he has found that his prostate has now been, it's a process called active surveillance.
Yeah.
And he has found that his PSA has settled into a static position, or more or less static. Because the PSA expression is exacerbated, if you ride a bike or if you have an inflammation or whatever. So it's not just the cancer that will elevate the PSA expression.
Oh, okay.
I, for instance, I have a very friendly GP, and he gives me a wad of pathology requests whenever I go see him every 3 months for an injection, and I have a pathology test every month. So I have a very, very clear idea of what my PSA is doing month by month by month by month. And I've got all that plotted in an Excel spreadsheet, so that it's very easy for me to get trends established before they really get serious.
Okay. Did this guy you're talking about down in Melbourne, has he had a biopsy?
Oh yeah.
Oh, so he knows he's got cancer in there.
Yeah.
Oh, okay. Okay.
Yeah. Because there are multiple forms of prostate cancer. There's really fast growing stuff and there's really slow growing stuff. Yeah. And it just depends on the luck of the draw as to whether you've got slow growing stuff or fast growing stuff.
And how do you know? Is that based on your PSA, is it?
Yeah, that's based on the doubling time of your PSA.
Okay. Yeah, so you get yours done every 3 months, do you?
No, I get mine done every month.
Every month? Okay, wow. Okay.
Wow. So my GP is very, very accommodating. He gives me a wad of pathology forms whenever I ask for them, and I just every around about the 10th of each month I go and do it, and
And do they give you the results, or do you have to go and see your GP to get the results?
No, you can request the results be mailed to you or emailed to you.
Okay.
And if it so happens that the pathology request forms that you're provided with don't have your name on them and your address, then you write it on it. And,
okay. Yep.
And then the pathology lab doesn't know who wrote it on it, so they just send it out. You won't get it in as timely a fashion as if you were a GP, but because they're of the view that your doctor should have it before you have it.
Yeah.
But you will get it.
Okay. Oh well, that's very interesting. Yeah. Like you go. Yes, Jim.
If you're on active surveillance, you must remember that you have your prostate and it will be producing PSA. So you will have an even amount of PSA, so long as you're getting the test done from the same lab every time. The only time it becomes worrying is if it starts going up. So although I'm with Yanni, I've had mine tested every month for the last 14 years.
Wow.
Some people won't be, some doctors won't be comfortable with that. So a more usual recipe for someone like you would be that the doctor would have a PSA test every 3 months, and if it appears to be going up, then they repeat that test within a month, roughly, just to see whether it was just, as Yanni says, sitting on a horse or a bike or time of day or whatever. And often they do 2 of those tests, at least a few weeks apart, just to make sure whether it was growing or not. The other thing I'd like to say about active surveillance is it's nothing new. we have between 15 and 20 years of evidence about it, and it seems to be that many people can at least delay their treatment until it's necessary. I mean, the good thing about that is seeing the treatment very often would lead to you peeing yourself perhaps continuously, you know, having 5 or 10 years, or I think the average is about 7 years, with not having to face that. That extra 7 years of not doing that to yourself, it's really worthwhile. And a lot of people just go through the whole 15 years and they never had to come back at all.
Okay. But are they saying that eventually it will progress?
No. There's a group of people, there's a fair sized group of people because unfortunately these samples contain people not like you, but people who have a Gleason score 3 + 3 = 6, who that will never ever metastasize, will never ever come back.
Okay.
So part of the successes are those people. So the data isn't separated, so we know how many of the 3 + 4 = 7, you know, lasted the 15 years, and how many of those were the people who didn't need it because they were Gleason score 6. So no absolutely firm guidance ever in this situation.
Yeah, sure.
But at least lots of people delayed it for quite a long time and enjoyed their lives during that period, you know.
Yeah, quality of life's pretty important.
Yeah.
Well, thank you very much, Jim.
You're welcome, Damien.
Yep.
Thanks, Damien. You got any other questions, or anybody got anything to comment about Damien's situation? Rightio. Well, Damien, you've got a decision or two to make between now and the end of July.
I certainly do.
And we wish you well with whatever decision you make.
Thank you.
No, all the very best. Roy, did you get your phone off mute?
Can you hear me now?
Oh, wonderful. Yes, we certainly can. Well done.
Yeah. On the Zoom part was on the thing. Okay. I'm just querying about, as I'm on 2 types of hormonal treatment, an Eligard and an Abiqua. And I was wondering if anyone is having hot flushes, and does acupuncture actually help for the hot flushes?
Rightio, you've thrown it out there. I know Eligard does cause some men a lot of trouble with hot flashes. I can remember being at a Brisbane meeting one night years ago, and there was a guy there used to change his pajamas twice a night because he was on Eligard. And over the years, we've had a number of people on this telephone meeting, Zoom meeting, that have had issues with hot flushes and or hot flashes, and but I haven't got a clue whether acupuncture helps. Jim, do you have any idea, or anyone else have any comment to make on that?
Anything that you believe in seems to help. When they did a trial of the acupuncture, they had fake acupuncture somehow, and the trial didn't work. Nevertheless, people who were on the trial, even when they found out that they were, you know, in the non-acupuncture part, they continued and continued reporting that it was going well. The other thing is that sometimes it fades over time. There are 3 drugs that are reported to to work. But all drugs have side effects, and most doctors won't prescribe those drugs until you've had a fair bit of time to, say, 3 or 6 months or even longer, to settle down and seeing whether you can live with it.
Yeah, I get that. I had a lot of trouble with the sweats, and they put me on a drug to stop that, and I got massive headaches. So I've been weaning the drug as well. And also, because I'm on those 2 drugs, you can't do the Nubequa without the Eligard.
Yes, yes. Or some kind of hormone therapy, and changing brands doesn't make any difference. The problem you've got is with low testosterone, because the hormone therapy is to take away your testosterone so it doesn't feed the cancer. So, yeah, one of these cases where
you're damned if you're damned if.
As I said, that there are 2 other drugs besides the one that you've had, and it'll be up to your advising medical oncologist whether they think you'd be a candidate for one of those 2. Yeah, sorry about that, Roy. I wish I had some better
Thanks,
news.
Jim. Any other comments or questions to Roy? Yes, John. John Timoshenko in Melbourne.
Yeah, just unmuting. You could try an estrogen gel patch that you can put on. Some of you guys know John Boosma, and he went on to hormone treatment and found he was really suffering from the flashes, and his doctor suggested an estrogen gel patch that he put on, and he reckons it's fantastic. Sort of really helped him a lot. So that could be worth a try. I'm not sure.
Thanks, John.
Jim here. Estrogen patches are in fact usually a good idea, but won't be allowed on the Nubeqa that you're on, and they'll want the old-fashioned type of, a different kind of getting rid of your hormone therapy. So it's a good thing for most people to consider, but your doctor will want you on the original kind of hormone therapy for Nubeqa.
Right. Thank you.
Sorry about that, Roy.
Oh, well, you have to live and learn, don't you?
Oh, it's better if you don't have to. So it's not much fun. So
Right.
It's not. Yep. That's why we need more research all the time, isn't it? So it is.
Yeah, very true.
Anyone else? Yes, sorry, Roy.
No, you're right. I'll have to go.
Right. All the best. Mark, did you have your hand up? Mark Godfrey?
Yeah, I was just going to say, on the Eligard, I had sort of hot flushes, but they weren't that bad. But since I started on the Nubequa, it did make them a lot worse. But I just found, since I started on the Eligard in February last year, I just sleep with a ceiling fan on, and I find that just helps. So I don't think I think there's probably been 2 nights since February last year that I haven't had the ceiling fan on, and they were really cold nights. But yeah, I find that sort of helps a bit. But yeah, they've definitely gotten worse since I started on the Nubequa a couple of months ago.
Right. Yes, Yanni?
Is there any possibility of, instead of using Nubequa or darolutamide, to use something else, like Xtandi/enzalutamide or one of the other 2nd generation drugs? Because I've been on Xtandi now for about 5 years, and I sort of get a bit warmish a couple of times a night, throw the blankets off for about 2 or 3 minutes, and then Bob's your uncle.
Yeah, I have a lot of trouble sleeping at night.
Once you come off the big one,
Yeah.
the government maybe won't allow you back on it.
But once you come off the big one, there's a chance the government won't allow you to go back on again at a later date.
Absolutely. Yep. Most of these novel therapies are one shot only. So you're getting to the stage where you've got to have this conversation with your medical oncologist.
Yeah. Yeah, I was just asking if anyone, acupuncture, alternative treatments might have helped somewhere, but obviously not.
Not amongst this group anyway, Roy. I'm sorry, we haven't heard of anyone that's been successful for over the years. So
okay, thank you.
Sorry about that. Who else would like to have a say? How are you going, John? John Timoshenko?
Yeah, thanks. I'm doing well. I just had a PET scan and it's undetectable. My PSA is undetectable, so my oncologist is pretty happy. So yeah, the hormone treatment that I'm on seems to be working for me.
Yeah, good news. Thank you.
Yep. Okay, and on that note, I'm probably going to have to sign off.
Yep, righto, John. All the best.
Okay. Thanks.
Enjoy the coast.
Will do.
Righto. Bob Owen, you're on mute. I'll see how you're going.
Here we go. Can you hear me?
Yeah, thank you.
Well, it's been a bit of an interesting turn actually with me. I started, when I was diagnosed over 2.5 years ago, they did a PSMA PET scan, and they found METs quite extensively. They started me immediately on chemo and ADT Firmagon. Now, during that 2 years, the PSA dropped to the lowest point was 0.25. Now, since October last year, it's been gradually, very slowly going up. So in the last 8 or 9 months, it's gone from 2.5. The last one was 1.1. Now, when it got to 1, and I'm assuming this is what happened, when it got to 1, the doctor recommended I had another PET scan, which I did. And that PET scan showed that most of those METs had gone, apart from the original tumour, obviously, and one on a bone, on a pelvic bone. Now, I'm only assuming that because these METs have disappeared, the number now is less than 5. So therefore, he is now putting me onto radiation. And I see the radiologists in just over a week's time. So I'm not sure what will happen there. But I'm just making these assumptions that because the lesions, the METs, didn't show up on the PET scan I had a couple of weeks ago, means that there are now less than 5, and therefore I qualify for radiation. And as I say, I don't know what they're going to tell me, but that will be on the 11th of June. So that's me at the moment.
Thanks, Bob. That's an interesting situation you find yourself in. And Tony Maxwell would think it was great if they could radiate those few spots and treat that. Any other questions or comments to Bob?
Yeah.
Jim?
Kind of offer a great deal of help. Just be keen to hear what the radiation oncologist says. the spots are in. So the original. Where's the original tumor in your prostate?
Yes.
Okay, and the PET scan spots are where?
I assume it's still in the, well, it will still be in the prostate. The main one that was detected way up front 2 years ago was, what's the bone across the pelvis? The ischiad? Some name like that. Anyway, that was about 1 centimetre long. Now that shrunk, and so did the tumour in the prostate. That also shrunk over the 2-year period. And I didn't get a full explanation, but I'm just assuming that because it was such a good result, after all this ADT, which has now been going on for over 2 years, he's decided to try further treatment with radiation.
That sounds what's going to happen. I mean, he's got a very clear spot there. As people have said, if you put some high radiation on a spot, it can work very, very well. As I mentioned before, it doesn't have to be called SBRT or SAT. There are lots of, practically any kind of external beam these days. The machine goes round and sends a beam down every 1 degree as it goes around. So what Alan described before as being special to one kind of radiation, that's fairly standard these days. So yes, so we're all very interested to find out what your specialist says.
Yes, that's Tuesday week, but I don't know what they will say. They might even say we won't do it. I don't know.
Yeah.
It'll be really interesting to see how that turns out, Bob. Will be interesting to get a result on where they go with you. So
yes, I was over the moon when he told me, but as we were walking out the door, I didn't get a chance. So I said, well, if these Mets have now disappeared over the 2-year period, why is the PSA going up? And he said, oh, well, there'll still be, I think that's what he said, there'll still be microscopic bits there, and you've still got the tumour and these 2 other lesions, 2 other tumours. Well, lesions, what do they call them? So I didn't get a definitive answer for that. But I had 2 PET scans, 2 blood tests a week apart. It went to 1.2, and then a week later, because he wanted to have the PET scan, it went down to 1.1. So a week's difference is a bit insignificant, but at least it went down. So I'm just waiting.
Yep. All the best. Tony wants to say something, then Yanni.
I think you need to get sort of a considered opinion from one or more radiation oncologists about what options radiation may give you in that situation. I mean, you've obviously got some cancer in the gland. Whether stereotactic radiation would be suitable there or not, I don't know. If you've got one site somewhere else, then that sounds like a candidate. But once again, it depends on where it is. If it's too close to other critical structures in your body, then you may or may not be able to have that sort of thing. So you need some general expertise on radiation oncology to help you make a decision on what to do next, I think.
Thanks, Tony. Yanni?
My observation was not so much with the radiation, but with regarding the degrelix. How are you coping with that?
Quite well, but I have noticed in the last couple of months that the day I have the injection, I feel not 100%. And once, maybe twice, I've had to go to bed really early because I got super tired. But the next day I'm up and around again. So whether it's coincidence, I don't know. But the day I have the injection seems to be the day that I don't feel 100%. After that, for the rest of the month, I'm fine.
Yes, Yanni?
Because I was on degrelix for about 7 years, and got to the point where my belly got so scarred that they found it difficult to find spots to do the injections, because the degrelix injections are quite large, and you know, they create the depot that dissipates. But I ended up feeling quite significant pain at the injection site and in the surrounding areas, and indeed flu-like symptoms for some time, generally a couple of days afterwards. And so I ended up moving, as has Jim, to triptorelin, also known as diferoline. And I just do not, and it's just as effective, if not more effective than degrelix, and there's no injection site effects, nothing, and it comes in 3-month or 6-month depots. So whereas the degrelix you have to do month by month or every 28 days.
Yes. So what was that called?
Diferoline or triptorelin. It's a dual name.
Brilliant. Okay.
I think you're pretty lucky. The minor side effects you're having from the Degrelix, actually, or Thermicon, with Bob, compared to what a lot of men have had over the years on this forum.
Yes, I don't worry about it. It's just an inconvenience, if no more.
Right, yeah, all the very best. And I want to get, Jim, quickly, I want to get to Peter.
Okay, Robert, that effect, I'm going. Talk to you later, Rob.
Peter.
I think I was going to raise it at the last meeting, but I didn't make it. I was referred back to my oncologist in late February, and I had a PSMA PET scan done. He checked the results. He indicated that the tumours had reduced from the previous scan, and he had ruled out lutetium-177 and put me in as a candidate for Zytiga, which I started. At the start of the Zytiga, my PSA was 0.5. 1 month later, it was 1.1. And on the 15th of May, it was 1.8. I went back to see my oncologist, and he had originally ruled out lutetium-177, but has basically put his hands in the air and said, we can't do anything else for you. Stop all your treatment and go and have another PSMA PET scan done, and we'll look at lutetium-177. So I'm just throwing it open. Has anyone dealt with lutetium-177 in their treatment?
Do you have your hand up, Charles, at all? Well, no, right, sorry. Now, we haven't got anyone here at the moment, I don't think, Peter, that's had lutetium-177. Over the years, we've had a number of people that have had lutetium-177. Do you got any comments, Yanni?
Yes. one of my good friends, Barry Eldfield, he was on lutetium-177 for about 5 years. I went through I think probably 7 odd treatments of lutetium-177, and he said that the primary side effects that he encountered were an impact on his tear, eyes, tear glands, and also on his salivary glands. So he had dry mouth issues, but he overcame those, with hanging onto a drink bottle and what have you. But the lutetium worked amazingly well for reducing mass metastases, and reduced those down to effectively 0. But it sort of lasted after each treatment, it sort of lasted about 4, 5, 6 months before he'd go and get another treatment. So he and I both concluded that if you use lutetium, you've got to have some sort of systemic follow-up to metastases at bay and stop them from spreading around, even in minuscule proportions.
Yeah, thanks, Yanni. My issue was the fact that my oncologist basically dismissed lutetium-177 out of hand on the 26th of February, but on the 15th of May, he's basically said, no, we need to go down that path. Without checking another PSMA PET scan, and his initial approach would be 2 to 3 sessions and then have another check on it. Well, that's $30,000. So, yes.
Barry, the person that Jan is referring to, he started off on a trial, and he was in Melbourne at the Peter Mac Hospital, and I don't believe his cost him anything at the time. I don't know whether the latter ones did or not, but I don't think they did. No.
But what it comes down to, as far as I understand, Pete, is that if a gallium scan works and identifies where your lesions are, where the mets are, then a lutetium-177 treatment will work equally effectively, because by if the lesions show up on a gallium scan, then that indicates that you are PSMA avid. In other words, your cancer cells give off the PSMA, and on that basis, there's absolutely no reason why the lutetium-177 shouldn't work. The only issue with lutetium-177 is that I understand that there, I don't know if it's still the case, but about a year ago, there was a shortage of lutetium-177 because the manufacturer in the USA stopped producing it or something like that. And it was only available from I believe, the Netherlands.
Well,
maybe that influenced his thinking at the time.
I don't know, but there's only one hospital here in Brisbane that does it, and that's at the Wesley where I go to. So, but no one can sort of give me the success rate. From what I've read, is that lutetium-177 is very effective for men with a high rate of metastatic cancer. Mine was prostate, lymph node, spine, and 2 ribs. And over the last 4 years, with all the treatments I've had, which has included 2 lots of hormone treatment at the same time, radiotherapy and chemotherapy, the tumours have reduced but he's just sort of put his hands in the air and said, well, stop everything and we'll have a look at lutetium-177.
I think the one thing about lutetium-177, and Peter Mac won't treat anyone with lutetium-177, and I'd stand corrected on this. They do a gallium-68, PSMA gallium-68 scan. They also do an FDG-18 scan. And if something shows up on the FDG-18 scan that isn't on the gallium-68 scan, they won't give you lutetium.
Yeah.
So if it gets, yes, sorry, Yanni.
And I haven't checked lately, but as of recent times, Peter Mac were running trials with various combinations of lutetium with PARP inhibitors, or with immunotherapy, or with some other mix of stuff. So it might be worth your while just checking out what Peter Mac has on offer.
Sometimes they have a partner at the Royal Brisbane Hospital in Brisbane that they run trials with. Peter Mac, I believe.
Yeah, well, there is a trial at the moment at the Princess Alexandra, but it's not on lutetium. It's on some other proton isotope thing that they're doing a trial on.
Well, actinium is the other go at the moment, and they've decided that the scientific community has because the lutetium treatments have been cornered by a commercial organisation. Peter Mac was exploring the use of actinium as another isotope, and some sort of lead isotope as well. And my understanding is that actinium is actually supposed to be more effective than lutetium because it doesn't
it's an alpha drug, and actinium is a beta drug.
Say again?
Lutetium's a beta drug, and actinium is an alpha drug, isn't it? So the alpha drugs are better than the beta drugs, potentially. So if you could get onto an actinium trial, I wouldn't be too frightened about that, Peter.
Yeah, exactly.
Tony here, can I just interrupt for a sec?
Yes, Tony.
I think we've got a lady called Katie, and I've just forgotten her surname, who's a researcher and has joined the research team at Peter Mac. And I think she's going to be talking at our next meeting. Is that
true?
Is that the case?
Yep. Yep.
So maybe she can add some extra information in regard to what's going on at Peter Mac and places like that with lutetium or actinium or whatever the heck.
Yep. Good point.
Thank you.
Right. Any other comments to Peter? Rightio. Well, anybody else got a comment or a question? Ian, have you got anything to add, or?
No, I don't see my specialist until 20th of June, and so I've got nothing to add to my situation at the moment.
Righto. Well, we wish you all the best. Anybody else got a comment, or have I missed anyone?
Sorry, I'm going to leave right now. Thanks a lot, guys.
Yeah. Righto, Charles. All the best. Good to have you.
Thank you.
So I'm still undetectable. So
good, Yanni. Me too. So, rightio. We might wind it up if no one else has got anything. Tony, do you want to say something? No. Rightio. Well, thank you very much, everyone, for your attendance, and wish everyone good health. All the best.